What comes to your mind when I say sickle cell disease? Chances are that you're thinking of something hematological. But have you ever considered the impact of social stigma on coping with sickle cell disease? This is EHA 2019, and I'm delighted to welcome Kofi Anie, who is, for a change, not a hematologist, but a psychologist, and was involved in one of the EHA's topics and focus sessions here in Amsterdam. Kofi, welcome, and thank you for being with me today. So, as a psychologist and as a patient, a sickle cell patient, would you say that the psychological needs of someone with sickle cell disease get as much attention as their hematological needs?
I would say overall no, but it's getting better. I've been working in the field for quite a long time, and over 20 years ago I had the opportunity of working as a psychologist predominantly with people with sickle cell disease and also patients with thalassemia as well. But in my practice in one of the London teaching hospitals, which is affiliated with Imperial College, I kind of have looked at how things have changed. When I started working in the field, there were hardly any psychologists like myself. But in recent times, like I said, it's gotten better. And now we have psychologists, even if they're not working full-time in the field like myself, some of them are doing work that is substantial in terms of the amount of hours or the amount of sessions that they are working within.
And did you find at the beginning of your journey that there was obviously a lot of unmet need in a way?
Yeah.
And what else have you noticed? Obviously the service is a lot better,
Yeah.
but have you noticed there's a benefit to patients report that they appreciate that input?
Absolutely, and I think even in terms of recent surveys with patients, patients do appreciate that psychological support is being provided, but they also say that it's not enough. And that sort of confirms my own view that even though they know that there are available psychologists that can support them, in most cases where you don't have the predominance, and this is especially in areas just outside London, or if you go further out into other parts of England, you're not going to find the specialized services, and they have to rely on generic services in terms of in children it will be child and adolescent mental health services, in adults it will be adult mental health services, and patients have recognized that there's a difference in having specialists as opposed to generists.
Sure, yes, I know what you mean. It's a very specific condition, isn't it? And just thinking about sickle cell disease itself, you know,
Yeah.
we often think in medicine of complications being physical ones like vaso-occlusive crises,
Yeah.
but stigmatization and stigma itself is also a complication. How big a complication do you think that is?
I think it's really huge, and most of the time people may not recognize it just because it's kind of unconscious, or they are inadvertent things that we probably wouldn't take notice of. So if you look at stigma generally as a social concept, it's just being different from the perspective of the patient, being different from other people. So if you look at it historically, stigma might have been defined as people actually coming along from different backgrounds and being identified as being different, either socially, culturally, or for some reason, because they might have some sort of disability, or they might have something that people can identify them that is different from, let's say, the norm. So I think that impact in terms of patients is very big. And if you look at maybe people not understanding sickle cell disease, and I'm referring to health professionals, might misunderstand that the impact of stigma in the terms of dealing with patients differently and the burden that the patient or the individual or the family has to face is what creates that impact psychologically. And we know that emotional feelings, emotional sort of behaviors that people with sickle cell have to live with makes it difficult for them because it has such an important component in managing their symptoms, their pain, and everything else on a day-to-day basis.
It's clearly a big issue that sounds like it's not been given enough prominence in terms of the way clinicians approach it. How do you think clinicians, hematologists and other clinicians in the medical sphere can actually help?
Yes, I think they can help by trying to understand some of the facets that lead to people being stigmatized. So, for example, just the patient talking about the severity of their pain and not being believed. So it means that obviously we are going to undertreat that patient's pain, and that is a big problem because sometimes patients would say that they just feel that doctors or nurses don't understand what they're saying. So I think things like that, which makes them feel that they are different, is really what has that sort of big impact.
And in medicine, that what you're saying resonates very strongly with me as a primary care doctor myself, and I see exactly where you're coming from. And in medicine, we're taught to use a biopsychosocial model, which some people agree with and others don't. But if we separate those out in terms of the stigma part of sickle cell, can you talk a bit about that and what your approach would be if you were giving a 101 to a clinician just in terms of tips?
Yeah, so I would just look at some dimensions of stigma, and I think you can highlight three key areas. So one is obviously the social impact, whereby you look at how society or the public in general will look at people with sickle cell disease. And obviously, historically, it's been something that has been identified as being predominantly affecting black people. And a lot of patients to this day would believe in that. So that is a very big social impact in terms of how people are viewed as a minority kind of population of patients. The second area that you can look at is I would classify as psychological well-being. So things like the stresses and some of the things that we've talked about is just like the mood and the different changes that emotionally a patient has to go through. So whether they are depressed or whether they are anxious or whatever, and what would feed into those things. So for example, if they have the feeling that there are problems associated with sickle cell disease are not well recognized, it affects their psychological well-being, which then feeds into the medical outcomes. And as we know, people who have emotional problems generally would have problems with their symptoms, exacerbation of symptoms, and I think those are the sort of areas that I think we need to focus on. And then the third thing, which again feeds into those two concepts, would be the relationships that patients would have with their healthcare providers, and in this case it could be doctors or nurses or even psychologists like myself. Is again what we might maybe subtly make the patient feel that they are being stigmatized, because again they are sort of looked at as being different from others. And so if you look at those three areas together, I think it gives you an idea of some of the main components or some of the main dimensions regarding stigma.
That sounds very useful, and it's quite a 360 type approach.
Yes.
That and We're in the business in a way in healthcare of data and measuring things, which
Yeah.
I don't always think is particularly helpful.
Yeah.
But are there any tools to measure stigma?
Well, there are few, I mean, specific for sickle cell
Yeah.
disease, but there are obviously, in terms of psychology broadly, there are various questionnaires that can be used to measure stigma. In terms of sickle cell specifically, some work has been done in the States, whereby a couple of very good psychological instruments specific to stigma and sickle cell disease have been developed. But I think sometimes when people are doing research and you want to, in a way, apply the research to a clinical setting, when you have a very lengthy questionnaire, that may not be the most effective way. So I think we probably need to look at some simple tools that can capture a few concepts broadly and quickly in a clinical setting, maybe like in an outpatient's clinic or whatever. Then we can use that as a way of implementing some changes.
Absolutely. And moving to this Congress,
Yes.
your topics and focus session, what were the key messages from that you were delivering?
Okay, so I tried to, in the short presentation, which was about 20 minutes, I tried to give a historical perspective of stigma from the point of view that there was a very prominent person by the name of Linus Pauling, who was an undivided Nobel laureate, who also had a landmark publication in terms of identifying sickle cell disease as a molecular disease. But at the same time, he created some controversy with a speech that he made in terms of identifying people who are carriers of the sickle cell gene with a mark, like a tattoo on their forehead. And that goes back to the actual original Greek definition of stigma, whereby you put a mark on a person to identify them as being different or being devalued. And his point was that we needed to identify people who are carriers of the sickle cell gene, because then you can stop them from getting married, and that would eventually lead to the disappearance of sickle cell disease. So that it was one of the very key historical examples that I tried to portray in the talk, that we've come a long way, but people still hold that view, because if you go and talk to policymakers, and some governments would say, if we give you funding for sickle cell programs, how are you going to control the numbers? Which means that how are you going to find a way of stopping people with sickle cell trait from getting married?
Yeah, it's really powerful listening to you say that, and I didn't know that about Linus Pauling. I thought you were going to talk about something else that he'd done, but in the actual session, so how was it received, and did you find there was a lot of
I think it was
input?
received very well. But also I went on to describe some of the concepts like I've mentioned, and giving examples from not only Europe but also other countries like Africa, where I've had the opportunity of working with people, either patients themselves with sickle cell disease, or also in terms of people who are trying to develop programs like newborn screening in various African countries.
And was there a lot of audience participation?
Well, a little bit, because there wasn't too much time for interaction. Like I said, it was a very limited time in terms of the entire session, and I think maybe next time we should have the opportunity of more interaction. I had one very good question at the end, which was relating to what we can do about it, because one of my colleagues from London said, they have a patient who looks at sickle cell disease as a punishment, and how we can address that. But I think one of the areas in which we can start addressing is first to identify that people have a stigma. We may not have defined it in the past, but then using that as an opportunity to educate and in a way debunking some of the myths and misconceptions, because that's what we try to do in other places where understanding of sickle cell disease is very much based on cultural beliefs or religious practices.
Yeah, absolutely. It's been absolutely fascinating talking to you, and I'd love to talk to you for hours on end, actually. I think the conversation could carry on, but unfortunately our time is up, and I'd really like to thank Kofi, Anie. Thank you so much for a refreshingly non-hematological take on a part of sickle cell disease that we might underestimate in everyday clinical practice, and that goes for other chronic conditions beyond sickle cell disease. So definitely spread the word on that, and thank you very much for watching this EHA expert interview. Bye for now.